What's up YouTube, Dr. Buck. In this video I want to talk about how to diagnose acute cholecystitis. I'm doing acute cholecystitis because it's one of the most common things that I see, and I think a lot of students also see that. So if you're somebody who is maybe a medical student, a PA student, an NP student, pharmacy student, nursing student, and you want to understand acute cholecystitis a little bit better and how to diagnose it, this would be for you. If you're somebody at home who thinks maybe you have acute cholecystitis, this might help you as well. So let's get into it. So the first thing we always do when we're trying to figure out a diagnosis is get the history and physical exam. So history of the patient, usually they come in for abdominal pain, so that's pretty easy. But when did it start? How long has it been going? Where is it? Does it radiate anywhere? Any alleviating or aggravating factors, things like that. So those are the typical things, and you guys know all that stuff. Gonna breeze over those things because this video, I just want to talk about the stuff that I find very helpful to focus on. So I like in medicine, there's so much stuff, right? There's so much noise out there. I want to find the signal in that noise. And so what I like to do is find those things, like in acute cholecystitis, which help me diagnose and not are just in everybody's diagnosis. Like if it's acute cholecystitis or appendicitis or diverticulitis, they all have fevers. So what are the things that are specific to this diagnosis that I can pull out and say, okay, now we're getting somewhere. Okay, so that's what I want to do. First, let me go to the iPad here, and you guys know I use a app called Biodigital. It's a 3D rendering app of the entire body. It's really awesome. Let's check it out here. This is, go over just a little bit of anatomy here first. And in acute cholecystitis, we're talking about the gallbladder. So here is the gallbladder. And the anatomy of this is essentially, this is the liver, okay? We have the stomach here, the small bowel, the duodenum, gallbladder itself, and the pancreas, okay? Now, the really awesome thing about this app is that it's you can just turn it around like this. And this is a super important thing that I use to show patients, because it's really not as straightforward if you just talk about it and kind of draw it in a two-dimensional board or a piece of paper or something like that in front of the patient. But if I can do this for my patients, then they really understand what's going on. So this helps a lot. In acute cholecystitis, go over real quick. The reason you have problems is because of the gallstones. So the gallbladder, if the liver makes bile, the bile trickles down these green tubes here, and the bile is something liquid that helps us digest our foods, especially fats in our food. And so this is the main bile duct, okay, behind here, and this is the common bile duct. And so eventually all this bile trickles down to the common bile duct, but there is a valve, okay, right at the opening between the common bile duct and the duodenum. There's a valve there, and that's closed while you're not eating. Okay, so the bile will then back up and then go into the gallbladder. The gallbladder stores and concentrates the bile, so when you eat, it squeezes. It's like a little muscular bag. It squeezes, it shoots it out, and actually we can see the connection here. This is really awesome too, because not everybody understands this. So between the gallbladder and the common bile duct is the cystic duct, and that is the duct that takes the bile from the gallbladder into the common bile duct. And so then it gets into the common bile duct, it goes down, the valve opens down here, right? And the valve's got a cool name, it's called the sphincter of Oddi. So the valve opens and the bile goes into the duodenum. It mixes with the food that was, basically mushed up by the stomach, and then it starts to digest, helps you digest the fats in your food, okay? So that is the rundown of the gallbladder. But what happens in about 20% of Americans, we develop gallstones, and these little gallstones, they're essentially the gallbladder concentrates the liquid down to a solid, okay? And then because this is kind of a round thing, they end up being like little stones, and they can be grains of sand looking things, and then kind of like, plug the pipe, so to speak, or they can be really large stones, and one large stone taking up the whole thing, 2-3 centimeters or something like that. But I would say the majority of people have stones that are smaller, but not quite grains of sand, but you can actually see like a little round ball. And the problem with this is if these stones get stuck in the neck of the gallbladder and they can't make it through the cystic duct and into the bile duct, then that plugs the gallbladder, and gallbladder then can't release the bile. And then if the gallbladder has an obstruction, it's going to try to squeeze against that obstruction, and then you'll develop pain. There's lots of things that can happen. We're going to focus on acute cholecystitis. So that is our issue. And let's go back then to the desktop and take a look at what we're looking at here. So first we're going to go over the symptoms, essentially the story, right, of what's going on. So the story is typically in acute cholecystitis, okay, the patients have between 1 day and maybe like 4 or 5 days of pain. And acute cholecystitis, first of all, is an infection. It's inflammation, but it's also an infection of the gallbladder. So when the gallbladder gets blocked by those stones, there's typically some bacteria in and around the bile anyway, because it's sort of kind of part of the GI tract. And so that bacteria in the gallbladder essentially gets trapped, and either the wall can get infected. A few things can happen essentially. The stones that block the gallbladder cause essentially the gallbladder to swell up. There's a fluid exchange between the wall of the gallbladder, and essentially what happens is you get fluid into the gallbladder, but it doesn't get out. And the gallbladder swells up, and then it can cut its own blood supply off if it gets really, really big. So when you have an obstruction and that organ gets really big, the blood pressure to that organ, usually it's okay going into it, but it can't get any venous return out of it because the pressure of the organ gets higher than the venous pressure return. And so then you're pumping blood into it and not coming out, which makes it worse. It causes more swelling. And so that can happen, as well as the bacteria in the gallbladder itself. The lumen of the gallbladder can proliferate and just have pure pus in there. It's very similar to acute appendicitis, what we talked about last week. So it's essentially in acute cholecystitis, you're getting this inflammation and infection, whereas like chronic cholecystitis is basically just inflammation, not really infection so much, okay? So that's important when we're looking at the labs and things like that. We'll find an acute phase and like a chronic inflammation. Let's go back here. So if we're looking for the history, typically it's abdominal pain, fevers and chills, some nausea and vomiting. That's very common. Malaise, they just don't feel right? They may have some myalgias. Those are very non-specific. And then they may have some jaundice. Now, jaundice takes us into kind of a different territory. And let's go back to the iPad here. Because if the patient is jaundiced, then that means one of these stones has gotten caught probably in the common bile duct. And once the common bile duct gets obstructed, the bile will back into the liver, and then that bile, when it goes back into the liver, will kind of leak essentially into the blood. And then if you have a high bile count, essentially bilirubin in the blood, then you'll have some jaundice. And jaundice is essentially they just look yellow, okay? Their eyes, they get the scleral icterus, so the eyes turn yellow usually first. Their skin can appear yellow. They can appear like sort of tan almost. But so you kind of have to be a little bit looking for that when a patient comes in, because you've never seen them before and you don't know if this is a tan or are they actually yellow. So pay attention to that. It's kind of a different entity, that's choledocholithiasis, and when common bile duct gets a stone, which is a little bit different from acute cholecystitis. They can have both at the same time, that's true, but we're going to talk about acute cholecystitis. So we're going to say, yes, they can have jaundice, but note that that is indicating something else is going on than just acute cholecystitis, right? So we have these symptoms, typically 24 hours, could be less than 24 hours, 5 days, 7 days, something like that. A lot of times people, when you ask them, have you had this type of pain before? They'll say, yes, I had it 6 months ago, I had it 2 years ago. Oh, every 4 years I get this, and this time it just didn't go away. That's the typical acute cholecystitis. They've had biliary colic or chronic cholecystitis for a long time, and then all of a sudden they got infected and now it's not going away and they feel really bad and drove them to the hospital, the ER, where before it would go away, they'd tough it out and then it'd go away and they'd say, oh, I'm fine. So they never were seen for it. Lots and lots of people, and sometimes it's 10 years of pain over and over. And in fact, I ended up taking the gallbladder out of one of my friends, and she had abdominal pain for 10 years and she never knew what it was. And then finally she came in with acute cholecystitis, took it out, and then she never had that abdominal pain again. She didn't realize she was having biliary colic and chronic cholecystitis for like 10 years. So back to the symptoms. So the second thing is running through this really quick because I want to talk about the things that are really important, and also I want to try to make these as short as possible. So this is not a comprehensive dissertation on acute cholecystitis and the symptoms and what happens and stuff like that. So the physical exam, typically they just have tenderness in the right upper quadrant. So, you're cutting the abdomen in 4 places, the right upper quadrant's up here. They have a Murphy sign. Not everybody has a Murphy sign, but it's a pretty good indicator. So, and Murphy sign is pretty easy. Essentially, you just push in the right upper quadrant, kind of underneath the ribs, and you have them take a deep breath. What that does is that brings, when they're laying down, right, when you're standing up, the organs are hanging down a little bit. And so the gallbladder will be a little bit under the ribs. Or if it's really distended, it could even be in the right lower quadrant, which doesn't happen often, but I've seen it. So typically you have it in the right upper quadrant, but when they're laying down, right, the gallbladder goes back up underneath the ribs. And so when you push in the right upper quadrant, just underneath the rib there, then sometimes they don't have significant tenderness. But if you ask them to take a deep breath, that flattens the diaphragm out, pushes the liver and the gallbladder towards your hand. The gallbladder may hit the peritoneum or the inside of the abdomen and cause pain, and they may stop inspiration. So that is a positive Murphy sign. When you palpate in the right upper quadrant, they inspire and then they cease their inspiration. That's positive. I wouldn't say it's like in acute cholecystitis, it's always positive, because a lot of times these patients have definitely a tenderness there, but they don't stop with inspiration. So that's not classically a Murphy sign. The other thing on physical exam is sometimes they have jaundice, and we talked about that. The reason they have that is because it is a common bile duct CBD stone that is, blocking the pipes essentially. So then we go to laboratory values. So this is kind of what differentiates a lot of other things. And I think it's in the textbooks, they tell you, what's supposed to happen, and the AST and ALT are elevated, and the bilirubin, and the direct is this, and the indirect is that. From clinical experience and 15 years of doing this, I have found that it is not very specific when the AST and ALT are up a certain level. You may have in acute cholecystitis, the AST and ALT are up, or they may not be up, okay? And the bilirubin may be up, or it may not be up. And it may be direct more, or it may be indirect more. And I don't want to hang my hat on these numbers. That's what I guess I'm getting at. I skipped over everything else, but the white blood cell count in acute cholecystitis when they have an infection is generally elevated. It's not 30,000, but it's usually 14 or 18 or something like that. Over 20, unlikely. Usually it's something else, but it could be over 20. Typically in the teens, I've found. Hemoglobin, you're going to get a CBC, you're going to see the hemoglobin, make sure that they're not bleeding from something else. They don't have an acute ulcer, right? They're not bleeding from a duodenal ulcer or a gastric ulcer or something like that. So you always obviously want to see that. And then a UA, just to make sure that they don't have any other problems. They don't have a UTI, or they're not septic. Probably get blood cultures if white count's positive and things like that. So, and then the LFTs, and I think a lot of textbooks and a lot of people teach about the LFTs and how they're supposed to be. I've just found them to be, I'd say mostly correct, but if you don't have an elevation in the AST and ALT and bilirubin, and you have a patient who has fevers, chills, nausea, vomiting, right upper quadrant pain, and right upper quadrant tenderness, and then you get an ultrasound and it looks pretty good and they have gallstones, then I wouldn't say, well, the AST and ALT are not elevated and this is not it. I don't think that patient needs an operation, especially if they're right demographics. And of course, I skipped over that, but this is all stuff in the textbooks too. And yes, the 4 Fs essentially of gallstones is fat, female, 40, and fertile, which means they've had children before. So that demographic, and I would add on, if they're Hispanic and they have right upper quadrant pain and tenderness, I'd take their gallbladder out. Because if those patients have gallstones, the Hispanics tend to get it a lot more. And so they've got acute cholecystitis right now, or they're gonna get it in the future. And many times everything is equivocal and you're not sure what it is and you can't find anything else. The last test is to take the gallbladder and see how they do. And most of the time that actually cures them and they feel much better. So I've run into lots of patients who go in and out of the hospital and are seen by multiple doctors, and nobody wants to take their gallbladder out because we can't find any positive findings. And I'll talk about the ultrasound in a second. And I take their gallbladder out and they are better. And in fact, I've had a kid from Africa who had 10 years of abdominal pain as well, and nothing was really positive. And I said, I think it sounds like it's your gallbladder. Let's take it out and see what happens. But it is a test. And as long as the patient understands that's a test, and everybody understands it's a test, and everyone's okay with it, and it may or may not cure them, then I go ahead and do it. And most of the time, I found that does cure their pain. So, and that is a problem. So then radiologic examinations, ultrasound, ultrasound and CAT scan. Now, ultrasound is the main thing you're gonna get. Sometimes though, patients come with, they get a workup and they get a CAT scan first, and then the ER doc will say, hey, I worked this patient up, blah, blah. The CAT scan shows this, do you wanna get an ultrasound? And if everything fits, I typically don't have to have an ultrasound, but it's usually pretty good to do that to make sure. If things don't fit right, the story, the history and physical, and the labs and things like that, then I do ultrasound to make sure. But if they just come to me with a CAT scan and everything fits up pretty good, then I can say, okay, we'll just do that based on the CAT scan. So the ultrasound, though, is the main thing you're gonna get. And typically what you see is wall thickening is usually something that, most acute cholecystitis patients have on ultrasound is wall thickening, but not all. And if the other things are there, if they have gallstones and they have the rest of the story and physical exam and a white count, and they don't have wall thickening and they have stones and maybe they don't have pericholecystic fluid, then I do the surgery. If the patient has gallstones, obviously, if they don't have any gallstones, then can you have acute cholecystitis? Yes, there's acalculous cholecystitis, which is gonna be a different video. But if they don't have gallstones, then I'm very, very suspicious and I may go on to other studies. Pericholecystic fluid, very common, but doesn't have to have it for acute cholecystitis. So really, gallstones is the #1 thing. So if they got gallstones, they got a good story and all that stuff, everything else lines up, then I'm like, okay, that's fine. Many times, the ultrasound will say the wall is not thickened. So we're talking about over 3 millimeters. And then when I get in there to do surgery, the wall is very thickened. And so I'm not saying that it doesn't correlate. Many times when it says the wall is thickened, yes, it's thickened, but many times I would say, maybe 25% of the times, it says the wall is not thickened. You go in there and the wall is definitely, of the gallbladder, is definitely inflamed. So I don't hang my hat on that. CAT scan, and let's see. And essentially you're gonna see where we see the gallstone in there and the arrow's pointing in here. You see the gallstone, you see some haziness around the gallbladder and gallstone and maybe a little fluid in there. Essentially you're just looking for like the haziness. That will tell you that is inflamed. The gallbladder is inflamed. There's inflammation, there's fluid, there's cells around the gallbladder. Just like when you smash your thumb, it swells up. That's what's gonna happen with the gallbladder too. All the inflammatory mediators and cells are gonna come to show up to help, fix the gallbladder, which it won't be fixed until you usually take it out if it's acute. So, and then I actually forgot to put it on the slides here, but a HIDA scan. So the HIDA scan is interesting because a lot of people say, well, it's for acute cholecystitis. Most of the time, if it's really acute cholecystitis where patient's sick and they're infected, then I'm not going to use a HIDA scan because the HIDA scan takes a lot of time. It's nuclear medicine. Those are usually 9 to 5 hours, and patients may be coming in the middle of the night or at least later at night. And if you're concerned that they're actually sick, do you want to wait for a HIDA scan like another 24 hours? Usually not. And the other, I think, factor is that if everything lines up and they have an ultrasound that is equivocal, but they have nausea, vomiting, right upper quadrant pain and tenderness, and maybe a white count, and you don't see anything else that makes any sense, right? Then I typically don't do the HIDA scan. When I do the HIDA scan is either when I want to stall, right? I don't think the patient has it, I want to stall, or we have time, they probably don't have acute cholecystitis, and I don't want to do the surgery that night, okay? So that's typically when I use the HIDA scan. And the HIDA scan basically will show filling of the gallbladder with the radionucleotide or not filling. Okay, if it's not filled, then that means the cystic duct is blocked, and we're assuming it's from a stone most of the time, right? So that's how I use the HIDA scan. I know it's taught very differently, but I typically don't use it very much in acute cholecystitis. Okay, and then the treatment is laparoscopic cholecystectomy. A lot of people are doing robotic cholecystectomy now. I think there is certainly a role for that. There's a few things with the robotic cholecystectomy that you can see the cystic duct a little bit better. The main complication or problem with the laparoscopic or robotic cholecystectomy is injuring the common bile duct instead of the cystic duct. So This is a great picture, but what it doesn't show is when the gallbladder gets inflamed, everything around here, so the gallbladder, the common bile duct, the cystic duct right here, the liver, all this becomes inflamed, and it may all, like when you cut yourself on your skin, you see the skin pull in and scar in, right? Well, that's what happens, especially in patients who have over and over acute cholecystitis, or they get better, or biliary colic over and over, and they have, or chronic cholecystitis. That stuff starts to suck all in together and may stick together. And so then when you're trying to remove the gallbladder and also to find out where the cystic duct is, the cystic duct, common bile duct, and gallbladder may be smashed together, and you can't tell what's what, and you can't find the structures because they're all in this inflammatory mass. If you injure the common bile duct, then you have to have open surgery and get essentially like a choledocho jejunostomy or something like that. So, which is common bile duct to a small loop of small bowel. And that comes with other problems, other morbidity and things like that. So you don't want to do that. Happens in less than about 0.5% of all gallbladder surgeries, like all comers. So the really sick people, the people that have had pain for 15, 20 years, and just, a one-time acute cholecystitis. So most of the time, those are found in the patients that have had pain and inflammation over long periods of time, like 10 years. Typically, it's not somebody who just has like a one acute bout and then you go in and take the gallbladder out. Generally, the structures are all separated pretty good. So, and then open cholecystectomy, if you can't find the structures very good, or some surgeons every once in a while will go straight to open cholecystectomy. I did like 15 or 20 open choles when I went to Honduras for a medical mission because we didn't have any laparoscopic instruments there. So that was pretty cool. Yeah, I think that's about all I wanted to talk about with acute cholecystitis. So I'm gonna hopefully do one of these every week, and we'll talk about all the different things: acute cholecystitis, chronic cholecystitis, biliary colic, and then we'll go through the GI tract and just talk about lots of things. And I know this is not textbook stuff, but this is just, I guess, the nuances that I see that my brain has been processing over the last 15 years or so. So hopefully it helps you guys too, all right? So thank you so much for watching. If you're somebody that wants to get into medicine, whether it's PA school, NP, medical school, nursing, whatever, and you're having a tough time studying and you need to learn how to focus, concentrate, speed read, take tests, I have a study course. It's called studyhackers.com. Go check it out. Thanks guys for watching so much, and I'll see you in the next one.